燕霞，你那个棒棒糖的那个图从哪儿找着的呀？是你们的经典
嗯，
图？
就是为了一个比喻嘛，就是是
真的是
网上 search 的一个 puzzle，嗯，
挺好一个比喻，
蛮有意思的哈，
很有意思，很形象。你
形象。
看大眼一看啥都看不着，就觉得这真的是一样啊，所以你得真的是能够给它挑出来。
Recording in progress.
Yeah, 8 o'clock now, huh? Yeah, we'll probably give it a couple minutes. Yeah. Chris, I think you can stop recording now, and we'll start later. Like in
Recording stopped.
right. 现在 a couple more minutes for people to come in. Yeah. We'll start 8:02 probably, right? Yeah. Mm.
Yeah. Okay. So we'll give two more minutes.
Yeah. Yeah, we're about to start pretty soon. We're still seeing people coming in. Yep.
Oh, it's 9:02.
Okay.
Shall we start? Okay.
Recording in progress.
Hello, everyone. I'm Cui Chunhua. I'm a pathologist who works in Lehigh Valley Hospital in Pennsylvania State. I'm a lifetime member of ANACP. I will be your host for this evening's presentation. So welcome for joining us. First, a very brief introduction about our organization. So this is the website. So if you go to our website, you can see this is the full name of organization called Alliance of North American Chinese Physicians, abbreviated as ANACP. Under About Us, you will see the organization with our mission and also vision. There's information about annual meetings. There are also information about lecture series. Most of the previous lectures have been recorded, so you are welcome to watch them. And particularly a very useful content is the youth training program. So these are very helpful for the students who are interested in volunteering and also who are interested in medicine. So let's go back to our lecture today. So pathology is not a popular area in medicine, but however, it is very important because nowadays we do multidisciplinary patient care. So pathology is a very important part. So it is a true privilege to have Yanxia, Dr. Yanxia Li, to give us our introduction about pathology. I also thank you the audience for all of you for your interest in getting to know more about pathology. Yanxia, who actually does not need a lot of introduction, but I will still introduce her very briefly. Yanxia graduated from Capital University of Medical Sciences in Beijing with her MD degree. She attended Loyola University Chicago and obtained her PhD degree in cardiac electrophysiology. She did her postdoc research for 3 years at Northwestern University and came back Loyola for pathology residency training for 4 years, followed by 2 fellowships in hematopathology and surgical pathology, respectively. She is APCP board certified and hematopathology board certified. After her training, Yanxia began her pathology career in Advocate Christ Medical Center in 2013 and has been working there since. Yanxia is not only an excellent pathologist, she also plays a very active leadership role in her practice. She is now the vice chair of pathology in the department and the director of hematology in the lab. She is also our board member and treasurer of ANACP. In addition to her very accomplished professional career, Yanxia is well known by her friends for being very warm-hearted, caring, dedicated, and motivated. Yanxia is a very wise and intelligent person who has really good sense of humor, which I always want to borrow some. It is fortunate of knowing Yanxia and being a friend of her. A few house items before I transfer the podium to Yanxia. Please mute yourself during the presentation. Any questions, please type in Q&A box. You can also raise your hands to ask when the presentation ends. So now let's welcome Yanxia.
Thank you so much, Trinhua, for such a wonderful introduction. I'm going to share my screen right now so we can get started. All right. Are you seeing my screen?
Yes.
Okay. Let me, 1 second. Is it the full screen now?
Yes, it's full. Yeah, full screen.
Oh, good, good. Yeah. So good evening, everyone. Thank you for coming to tonight's lecture. I really appreciate your time, especially in such a precious Saturday night. So the title of my talk is Behind the Scenes of Healthcare, Demystifying Pathology. Let's get started. I have nothing to disclose in this lecture. No. I want to start my talk with the story of my 16-year-old son. He gets to know about some pathology from me here and there since I, bring some stories back home and share with him. And then he went to a camp, a medicine camp last summer in Northwestern University. They got exposed to many medical specialties, but not really in pathology. So he came back and got all excited, but told me that, Mom, I don't want to be a pathologist because there's like more fun in seeing patients. So I do acknowledge my 16-year-old son's feeling. Even some medical students and the residents of other specialties, for them, pathology is a mystery. So pathology is, often less visible to general public than other medical specialties. It is more of a behind the scene type of specialty, but it is very, very crucial for healthcare. Our audience today consists of a variety of populations, and most of you are physicians outside of pathology. There are some medical students, some residents, and other people not in medical field. All right. So Dr. Tao Wang, who is the leader of our educational community, committee initially gave a very mysterious, fun title to my talk, which is in Chinese. She called it 病理内幕. I found it really amusing. And I don't know, like, if you have ever heard about a way of describing pathology. Pathology is the best kept secret in medicine. All right. So I'm gonna keep going. All right. Yeah. So in today's talk, the general structure of my talk is about a pathology overview. And I will give you a general structure, divisions about pathology and pathology training, subspecialties about pathology, some like leading organizations, pathology, including CAP and CAPA, and pathology, science versus art. And I want to, give you some ideas how pathologists think, and some interesting cases and stories to share, and challenges, malpractice, and artificial intelligence in pathology, right? So we have a lot of content to go through. All right, so this is, my office, right? Most pathologists don't interact with patients. We work in offices. This is my cozy office, and then in a private hospital with approximately 800 beds. It's a fairly good-sized hospital. We have the tools, including a microscope, and we have computer monitors. And when the digital pathology comes in the future, we may not even need a microscope, right? So talking about pathologist lifestyle. So in terms of working hours, it may not be shorter or less than other specialties, but the flexibility is a big advantage. In the morning, I arrive at the hospital, arrive at my office. I usually start with a cup of tea or coffee, and I would go around in the office and say hi and chat with other people. And in the lab, so most of us like have breakfast in the hospital in the morning. We sit most of the time when we work. I would like after time to time to get up and stretch, right? But nowadays there are this type of height adjustable table desk, right? So you see this one. This is a picture from another pathologist in our office. She has this type of height adjustable desk. So you can alternate between sitting and standing, right? Okay, now pathology divisions. This is the structure and the training part of pathology I would kind of, show you. In terms of the education, right? It starts from high school, college, or undergraduate in medical school. After medical school, you will start a residency in pathology, right? After residency, it follows up with a fellowship. And after all the training, you become a pathologist, right? So in general, there's like two main branches in pathology. One is anatomical pathology as AP, right? Clinical pathology as CP. In residency training, there are three main options. One is a combined AP and CP training, which takes about 4 years. And this is most pathologists would do, the combined. Or an AP only takes 3 years, or a CP only takes 3 years, right? So after pathology residency training, there are usually 1 or 2 years of subspecialty or fellowship training. And the total training is about 5 to 6 years for you to, become a certified pathologist. So to share my experience, my personal experience of going through pathology residency training and fellowship trainings, just to give you an idea how the trainings were, I just, in general, I feel it was not too hard and probably relatively easier than some other clinical specialties, And since we don't have to stay in the hospital overnight, and I was a mother of 2 young kids when I started my residency, and I was able to spend some time with them every day after work. This could be a luxury for some other residency trainings in other specialties. So more about anatomical pathology, AP. In AP, you see there's a microscope I have on this picture, right? Surgical pathology to process the organs, the tissues is the bread and butter of pathology. There's a picture of how we process organs. Right? It looks like a little bit of like you work in the kitchen. It's a cutting board. We have specimens to cut, and then this is like bread loafing some specimen. If you have a good sense in the kitchen, you might have an upper hand in the pathology already. I'm just kidding. So gross or the dissect specimen. This is like one step, and the next is a microscopic picture and histologic evaluation. I'm showing a picture. This is taken from under a microscope, right? And another big part is a frozen section or intraoperative diagnosis. This is really exciting. It's like a front line of pathology. And we make intraoperative diagnosis. One patient is still waiting on the operating bed, right? Our diagnosis from the frozen section tissue really directs what's the next step the surgeon would do in the surgery. So we have some tissue sent from the OR to work with. A frozen block is made, and tissue is cut into a few micron thin slices, like shown on this picture. Right, this is the process, and the slides get processed quickly for us pathologists to read. Most of us render the frozen section diagnosis in 10 to 20 minutes because that's required for the OR to keep going in their surgery. Besides surgical pathology, cytopathology is a big part of AP, right? So cytopathology is to study single and group of cells using procedures like fine needle aspiration, which is an image-guided procedure, a lot less invasive than open procedures. Okay, there's a picture of a ultrasound-guided fine needle aspiration biopsy from a thyroid mass. And what they have is this type of cells, group of cells, single cells to evaluate. And then this picture, it shows a papillary thyroid carcinoma, right? And also cytopathology works on fluids like ascites or pleural fluids, and also pap smears. The last but not the least is forensic pathology, including an autopsies to determine the cause of death. A lot of us know Dr. Feng Li, who is a forensic pathology expert, and often teaches us so many interesting things that we don't usually get exposed to. Right now, so by the way, these are some tissue blocks. The tissues got processed and embedded in the paraffin, what we call paraffin blocks. Basically, they're wax, all right, to embed those tissue to get good support for us to make very thin slides for evaluation. Next is clinical pathology, another big branch or division of pathology. Clinical pathology is for laboratory medicine, right? We learn about how the lab tests are run, including the different sections. For example, blood bank, transfusion medicine, microbiology, hematology, chemistry, molecular pathology, informatics. Okay. So worth mentioning is that AP and CP are both two divisions of pathology in the US. But there are separate specialties in hospitals in China. That's like one of the main difference. And the pathology education and training in the US is very broad, very structured, extensive, giving you a training not only for diagnostic skills, but also how the lab is run. After training, most of the pathologists actually practiced anatomical pathology, meaning working with a microscope. However, all these laboratory or CP trainings serves as a very solid foundation for our overall practice. We pathologists oversee quality control, proficiency testing, laboratory management. So all of the US laboratories are under very strict supervision by higher centralized organizations. And the labs need accreditation and being tested like periodically from time to time. And I have to mention that our leading organization of US Pathology, a College of American Pathologists, CAP, briefly. All right, so CAP is a world's largest organization of board-certified pathologists, comprising approximately 18,000 board-certified pathologists in US, a leading provider of a laboratory accreditation and proficiency testing programs. I would like to introduce you this exciting news and Dr. Jim Jai. Okay, Dr. Jim Jai is elected to as a president of CAP for the next 2 years. He's from mainland China, just as one of us, and went like above and beyond. In this article, he shared his inspiring journey, which we all went through to fulfill our American dreams. As mentioned that he's arriving in US with only 2 suitcases and $166. And Dr. Jai shared, I consider myself incredibly fortunate as I'm living the American dream. Congratulations to Dr. Jai, who is going to lead the US pathologists for the next 2 years. And we're so proud of him. And our organization, ANACP, also congratulated Dr. Jai for his big achievement as a CAP chair, a president. And very importantly, I need to introduce you about CAPA, the Chinese American Pathologists Association. CAPA is not new to a lot of us. We know about CAPA, and a lot of CAPA members are ANACP members. CAPA has approximately 800 Chinese pathologists in US. And both CAPA and ANACP are my families. I do encourage more pathologists to join ANACP. A little bit more about specialties in pathology. So American Board of Pathology is one of the 24 American boards of medicine specialties, just like a board of internal medicine, board of pediatrics. And the pathology board outlines the divisions and subspecialties in pathology. Like we have mentioned in residency, right? We have all these divisions and combined APCP and AP or CP. So on this side is the fellowship training, right? The subspecialties, the board certified subspecialties. Although surgical pathology is not a board certified specialty, because it's bread and butter. I mean, we're expected to know surgical pathology. It's just for our practice. And a fellowship in surgical pathology really trains us to see organs and systems in depth. A lot of us do a 1 year of surgical pathology fellowship, either general or specialized in certain areas listed here, right? Different organ systems. For example, my practice, my training, I did 4 years of APCP, in my residency, I did 1 year of surgical pathology and 1 year of board certified fellowship hematopathology. That makes a total of 6 years in training before I work in my current job. In the United States, there are probably 18,000 to 20,000 pathologists. 70 to 80% work in community private practice. 20 to 30% work in academic or university practice. Okay, now let's move on. Pathology is critical, is to make diagnosis, right? And is it science versus art? I think it might be an interesting question to bring up. Pathology as science is a fundamentally a scientific discipline. It studies the disease processes, causes, and mechanisms. It understands how disease affects the human body at a cellular and molecular levels. Right? Pathology uses scientific methods, microscope, like we've mentioned in AP, anatomical pathology, laboratory tests, clinical pathology, and other advanced technologies to make diagnosis. Okay, I will give you an illustration here. Pathology is fun, it's cool, it's solving puzzles every day. This is how it goes. Trained eyes and minds will be able to catch outliers or bad cells, hopefully most of the time. All right, but you know we are human beings. I mean, so nothing would be perfect. It's just in this puzzle, I challenge you to find a hidden lollipop in the ice cream cone, right? So now you have the next 10 to 15 minutes to find it. I wish, right? Just kidding. Okay, I will give you the answer, right? This is where this hidden lollipop identified in the colorful ice cream cones. Right? The morphology of this lollipop is different from these ice cream cones on the background. Okay, so this is like if you can identify a bad cell in the background of a good cells. But if I introduce you pathology this way, other pathologists may not be satisfied. I say, something is like not complete or not all right. So I have something more important besides finding lollipops to aid our diagnosis. Very importantly, pathology is pattern recognition. That's one of the most important words. Those are the most important words in pathology realm. Pattern recognition, which is a low power appreciation of the architectures of the tissue, the cell, the structures. In this picture, the left-hand side is the glands in benign tissue. The right-hand side is the glands in malignant tissue. What you can appreciate, even you guys are not trained in pathology, the glands on the left-hand side are round, evenly distributed, respecting to each other. And the glands on the right side are irregular, kind of zigzag and overlapping, branching, kind of, not respecting each other. So benign versus malignant. This is the power of pattern recognition that we use, daily. I mean, this is like, we breathe in and out with this pattern recognition. Now, what do you think of AI? Do you think AI is able to help us for lollipop finding? Is it going to help us for pattern recognition? I will touch a little bit on AI at the end of the lecture. Dr. Li Minyu, who most of us are familiar, is an expert in pathology AI world. Right? Okay, I wish all the diagnosis in pathology is black and white, but that's not the case. Right? Pathology is also art. The art aspect of pathology refers to interpretation and judgment. we sometimes face complex and ambiguous cases. It requires a certain level of subjective interpretation and decision-making. This is considered art, right? And how do you diagnose this picture, right? Do you think this is a duck or a rabbit? And can you convince yourself or each other what it is? This may give you a sense of the art part of pathology for image and the recognition that we're facing sometimes. All right. Now, more about how pathologists work and think. Pathology is rewarding and challenging, right? Needless to say, our job is rewarding because we serve patients by making diagnosis. Without a diagnosis, it's like, they have nowhere to start how to treat the patient, what they're dealing with. So we make diagnosis and doing detective work, solving puzzles every day, which is very rewarding and it's a lot of fun. However, we're facing a lot of challenges. A job without challenges is boring, right? I hope to take you and dive a little deeper into a real world of pathology here. And I have some real cases and stories to show you as some important aspects of pathology, including clinical pathological correlation, communication with clinicians, and how we work up tumor cases, including grading, staging of those tumors, and pathologist's dilemma, fear, nightmares. We'll see how far we can go, right? Okay. Before I share cases with you, I want to, just show you a little bit of our decision tree, our decision-making process. And this is a diagram I made, a very simplified diagram, right, to show you how we think. And the first few seconds, we start looking at a slide under our microscope. This has started to form in our mind. Whether we need to decide whether this is a reactive versus a tumor, right? Reactive means it's benign, including infectious, inflammatory, trauma, drug effects, etc. And if it's not reactive, if it's a tumor or neoplasm, a neoplastic growth, we need to determine if the tumor is benign or malignant. Benign tumors, for some examples, are fibroids, fibroadenoma, lipoma. Those are good tumors, right? They're benign tumors. And the malignant tumors, we have a lot more to say. There are some big categories, including on the top layers, carcinoma, sarcoma, melanoma, lymphoma, and leukemia. Right? Under each big categories, there are tons of more specific entities. And we need to determine whether it's a primary tumor to that organ or a metastatic tumor to that organ if there's malignancy found. Okay. All right. Now, CAP. We've mentioned CAP. CAP and World Health Organization work together for tumor classifications. There's one example, the carcinoma of the breasts. We have many entities, or say specific classifications for a breast carcinoma. And okay, for the cancer entity, we need to do grading and staging. Gradings, to describe what gradings are, grading is to evaluate how ugly the cells are. They're low grade or high grade, right? And the staging, on the other hand, is to determine how aggressive or the behavior of the carcinomas at the time of diagnosis, including characters like tumor size, lymph node metastasis or lymph node involvement, and other organ metastasis. And then these are all very important characteristics when we work up tumors. in pathology. Now, case number 1. I would show this case to give an idea. Clinical pathological correlation is very important. The history, 61-year-old female who presents with right hand swelling and redness. What I have here is a picture, a microscope picture. This is a low power picture, all right? Meaning like you're looking at this picture from like a mile away. Okay, growth descriptions, you don't have to look into the details of the growth descriptions, but I will tell you what it is. It is about how we describe the specimen we receive in pathology. The source and the dimension, the growth experience, growth appearance, how they look, and how things are submitted in cassettes, right? We saw the cassettes or those blocks, paraffin blocks earlier. Okay, in this low power picture, you know, what's the pattern that you see? You see pink areas, you see blue areas. In pathology, the general way we describe, especially, you know, to people from other specialties, not in pathology, we say pink is good, blue is bad. You see pink and blue here, right? So the pink is usually the areas that is less cellular, is more fibrosis, or it could be some necrosis, which is, in this case, is necrosis. Well, the blue areas is more cellular or proliferative, you know, which can be alarming. Okay, a higher power view of the blue areas from the previous picture shows a mixture of inflammatory cells. What are inflammatory cells? We have neutrophils, lymphocytes, histiocytes, plasma cells. You know, there's a collection of mixture of those cells here without granulomas identified. This pattern recognition, this morphology architecture point to a process of infection. Okay, now we kind of, in our decision-making tree, I put this into a reactive, benign process. It looks like infection. We see this type of tissue from wound debridement all the time in pathology. And a descriptive sign out, descriptive diagnosis is made, extensively mixed acute and chronic inflammation with abundant necrosis for this case. However, this is not over yet. The infectious disease doctor, right, wrote some paragraphs of interesting notes a couple of days after the pathology diagnosis. I ran into him in the hallway in the hospital and started talking about this case with more history and more details. Actually, the patient's symptoms started 5 months before the pathology diagnosis, or say before the specimen was sent to pathology for diagnosis. It started in November last year. The patient started to have some redness and swelling in the third finger of the right hand, eventually got some papular lesions. And in December, the patient was started on some antibiotics, right? And the hand surgeon did an incision and drainage on her hand. In January this year, the patient started to develop some trigger fingers and underwent steroid injection at the base of the hand. In February this month, the patient developed some newer other areas of redness and the swelling in the right hand. In March this year, the patient had another incision and drainage and had to have some like pus material from her wound. They sent for a bacteria culture, but there was no growth. They could not identify any bacteria. And pathology was sent. That was from the previous picture you saw. And, you know, I rendered a diagnosis of this mixed inflammation necrosis. The patient was starting augmenting again. And now I'm going to show a picture. It might be a little disturbing to some of you. All right. This is from March this year. And the cut is from the incision and drainage, right? This is how the patient's hand looked. It's 5 months after she started having the symptom. Not over yet. More stories keeps coming. And the infectious disease doctor really added some interesting notes to his reports, his clinical notes. So he said the patient recalls gardening in fall, last year, and pulling some rose bushes, and then possibly poked by a thorn on her hand. And she has 2 dogs, 1 cat that sometimes scratches. And her children have 1 snake and 1 gecko. Right? Those are the cute little things she has in her life. All right. She has hobbies, including fish tanks. And she has 1 fresh and 1 salt water tank. She cleans the fish tanks monthly. In the tank, she has shrimp, crab, a fish, coral, right? These are all real notes. I kind of just simplified and then, make it more condensed for you to see here. But she has some travel history domestically, and she denies a history of tuberculosis. She denies a cigarette or drug use, drinks wine only occasionally. Definitely, the patient is living a very colorful life. But, what do you think now? Any clue? Do you think all these things are related to her injury, and which one could be the culprit, right? These are the questions that we have to ask by knowing the clinical history, by talking to the clinicians. So we decided at this point to do some more investigation, more digging. And one more thing we decided to do is to stain the tissue with acid-fast stain. Acid-fast stain is used to stain the specific compound in cell wall of mycobacterium species, right? So we don't have time to go into details about the mycobacteria species, but like the TB, tuberculosis, that's caused by a mycobacterial species, right? And microscopically, usually we see granulomas in the tissue, but not in this case. And this is what we saw under the AFB, the acid-fast stain. To my surprise, we have these organisms, this bright red rods. Okay, are highlighted in the the high power view of this picture. All right, these guys are the mycobacteria species. Okay, together with this finding and the clinical history, we revised our diagnosis. We added identification of the mycobacteria species, clinical history, exposure to salt and freshwater fish tank, raised the possibility of 1 bug called Mycobacterium marinum. But a definitive diagnosis has to be made by molecular PCR analysis, not just by the AFB and the stains in this case. What we did is we sent the test to University of Washington. Not everywhere can do this type of tests, right? And a couple weeks later, the results came back. They confirmed this is a Mycobacterium marinum. And it was finally, we nailed it, this organism. Okay, more pictures. This is we saw this picture earlier, was by the time of the diagnosis, but still 5 months after the symptoms started. And the patient was started on the combination of oral antibiotics, clarithromycin, and ethamatol for about 7 months total. Hands are a very difficult location to get to. So this is like how this disease or this wound healed over time. It's like this is almost like 5 months out. Eventually, finally, the patient's wound is healed, right? This is now when you handle a fish tank, I guess now we know what to do or what not to do, right? Okay, and I did some literature research. I found a very interesting article. This is in 2020. And in this article, it described just such a pretty much identical story as what we see in our patients. In this article, they described their patient had this salt and water tank, fish tank exposure, and this patient did some landscape work, which he might have a skin injury without even being noticed. So this is like somehow a rare but reported known entity. They're pretty cool. I think this is a very good case, and it's somehow difficult to miss without good clinical pathological correlation. All right, so the conclusion is like the clinical pathological correlation is very critical. Knowing the history, talk to the clinicians, and come up with a good diagnosis. Now, I will have a few cases to show quickly as a case series to show you my favorite organ, appendix. What's hiding behind appendicitis? Appendix is a small organ. It's over here. There's a little tail attached to cecum. Cecum is the starting point of our colon, right? So this is where appendix is. The first case, very briefly, a 68-year-old female presented 4 months before this surgery. So she presented with some right lower quadrant abdominal pain associated with some nausea, fever, and chills, and leukocytosis. And CT, the imaging shows it's like she had a perforated appendicitis and with associated abscess. At that time, the patient decided to go on conservative treatment with antibiotics. So it was probably not severe enough for them to say to have a surgical removal. Now, a few months later, she was told, yeah, now it's probably good for you to get a interval appendectomy. So the patient came in and the appendix is removed. This is a cross section of appendix. The lumen, right? This is the appendix mucosa, appendix wall. So this appendix is fairly normal looking. I mean, there's no acute appendicitis anymore. There might be some chronic changes with fibrosis. But what's kind of interesting is there's like an area of, what is this? I mean, for pathologists, we recognize that that's like acellular, like, no cells in it, but it's a mucin pool. But how can we explain that? I mean, it looks normal. It's like no, cancer, no neoplasm, but we have this. So what I did, and I asked our, the PA, pathologist assistant, to go back to the specimen and submit the entire appendix, right? Okay, to my surprise, when the entire appendix is submitted, I see more areas. If you can appreciate the lumen, all these glands are different from the previous ones. These are proliferative. These are hyperplastic. These are some, sorry about this, the terms that I use in pathology, because I have to, right? And so these glands are different. This is not a acute appendicitis or just appendicitis at all anymore. What we have in this entity is there is a neoplastic process, all right? It's called sessile-serrated lesion, right? Now, to change the diagnosis from a appendix or a possible appendix to a neoplastic process, right? Remember that decision tree? This is acute appendicitis or appendicitis is a reactive process, but now it changed to a neoplastic or tumor. So that mucin pools was an indication there was like some association with something else besides appendix, right? We need to be very sensitive and alarming to all these evidence. A scientific paper, an article that I cited here with a few sentences just to show you the importance of identifying this type of lesions in the colon, in appendix. It's like the cell-rated adenoma that's usually found in colon and are part of adenoma carcinoma sequence in colon malignancy, meaning this patient now is having a low-grade malignant a tumor, it's got low-grade malignant potential, meaning the patient is having a higher risk of developing malignancy comparing to the population without this type of lesion identified, right? So the difference is that the patient will have a more screening and surveillance in his life to screen if there's any other potential possible neoplasm, right? So, okay. After that incidental finding, I have another case to show you. This case is it's hard to swallow, but it's a good case to show. A 50-year-old female presented to ER with complaints of right lower abdominal pain. It's ongoing for a few days, 10 out of 10, very severe, right? The imaging shows there are acute appendicitis with abscess, and the patient underwent appendectomy. And she was found to have acute appendicitis with perforation during operation. So the presentations are similar. It's like pain, some, imaging would confirm, and the patient would have some symptoms related to fever, leukocytosis. Okay, so this looks like a busy slide. Don't worry about the details in the gross description. So grossly, they identified, I'll just tell you that the purulent, meaning pus, right, exudate and appendix, confirming, it's like acute appendicitis. That's what it does, right? It inflames and then get all this exudate. Okay, these are 3 slides. Okay, glass slides to see what the specimen looks, and this is what we will put underneath our microscope to examine. There are cross sections of the appendix with the lumen, and we also have the tips of the appendix. Okay, acute appendicitis, no problem. We identified acute appendicitis, meaning a lot of neutrophils, right? This is the area with abscess, with neutrophils, and that's a pretty good correlation. The clinical pathological correlation is made. It seems like a very good picture. Now I want to bring your attention to 2 foci, right? These 2 small foci, one in red, one in green. This little area is from this tiny corner of the specimen, right? Within the 3 glass slides. What I'm gonna kind of show you under high power are these 2 different foci. The red one shows this type of morphology, and the green one, this type of morphology. For our eyes, right, I'm not sure about how you guys feel. This is day and night. This is heaven and hell. I mean, these are absolutely 2 different cell types. This red one is malignancy. Okay, it's malignancy. The cells are big, irregular, and they're crowded, overlapping with mitotic figures or dividing cells, right? On the other hand, this focus is small. Cells are uniform. These are lymphocytes. So they're innocent lymphocyte in a cluster, okay? How are we able to identify things like this with, a appendicitis diagnosis made already? And this is a lollipop moment, I have to say. This is like a moment of prayer, and we need God blessing to find something like this, right? Very challenging and very easy to miss. So what happened to this patient? This is a story. So she was found to have a cecal cancer. Cecum. Okay, cecum is this pouch. That's a starting portion of our colon. And these are a few anatomical variations of appendix, how it's related to the cecum, right? And this one is the most common one, the retrocecal. It's called retrocecal location of appendix. Then that's what happens to this patient. And it ends up that this patient had a cecal cancer involving the appendix with complication of acute appendicitis. Then this is the story. Very astounding story, a very scary case. We pathologists may miss it, this malignant focus after diagnosing acute appendicitis already. All right. Okay, yeah, so what we learned about adult appendicitis, right? So appendicitis in general occurs most frequently between age 10 to 20-year-old with a slightly male predominance. And then patients who are 50 years old or older, some acute appendicitis were found to be associated with right-sided neoplasm, as these two cases I just shown, right? In fact, 2.9% of patients who suffered from acute appendicitis were found to have colorectal cancer compared to 0.1% who do not. So we are really careful about adult appendicitis, and we just have to be very, very thorough. And then next appendicitis is a 15-year-old. We learned, okay, from the previous slide, appendicitis occurs most frequently in a pediatric or young patient population, right? So are we off the hook when we look at a pediatric 15-year-old appendicitis who presented with 1 week history of pain, with this GI symptoms, leukocytosis, CT imaging shows fine. This is like consistent with acute appendicitis. And a appendectomy was performed. This is a low power view and a high power view of the appendix. Acute appendicitis, no problem. We have abscess and neutrophils, a collection of those. We have a case of acute appendicitis. Again, clinical pathological correlation is made. Another section of this appendix shows something else. In this 15-year-old, which was an incidental finding, was not expected. Nobody else knows about this until they send it for pathology. This is a cross-section of the appendix. Okay, the pattern recognition might be a little hard for you guys to view, right? With this image, but this area shows some funny-looking infiltrating cells, right? They don't belong here at this pattern. Okay. A higher power view of these cells, there are nests of these small cells, but they're not lymphocytes, all right? Believe me. And then these nests of cells kind of infiltrating into the colon, the appendiceal wall. The pattern is not for innocent cells. One tool we use in pathology is called immunohistochemical stains, where we use antibodies to highlight certain type of cells. In this case, this immunostain is called chromogranin. Chromogranin is specific for neuroendocrine cells, and it highlights in this brown color, right? This brown color, these cells. So these cells, right? And also these cells actually involving the outermost layer of appendix. This is the serosa surface. Okay, yeah, and on this immunostain, they are actually in this layer already. That's how aggressive, or say, the behavior of this tumor. Okay. I want to use this case to give you a sense of pathology report, the structures of pathology report, and how we report, make our diagnosis and different components, because I got some requests to say how we read pathology reports. And in pathology reports in general, you've seen like some gross descriptions that I have shown in the earlier cases, right? And we have the main section as the diagnosis, right? Over here, we have the diagnostic portion, which is the most important portion. And besides that, we have something called microscopic description. Microscopic description is to describe what we found under the microscope, in terms of the morphology, the pattern, the architecture. And we have a lot of pearls, we have a lot of buzzwords in our diagnosis, in our microscopic description. For example, here may not make sense to you, since these are like pathology terms. Nests of small blue round cells with salt and pepper chromatin pattern. Okay, so these are not just the random words that we throw out there. These words mean something. It implies something. This is how we use to describe neuroendocrine tumor, especially well-differentiated neuroendocrine tumor, which is the diagnosis, the incidental finding in this appendix. And in the diagnosis, we give the name of the tumor, the measurement, right? In this case, the measurement is 1.2 by 0.8 by 0.4 centimeter. And we give the how far it invades into the wall. In this case, it invades into muscularis propria. Sorry about the terms. Involving the serosal surface, meaning the outmost layer of the appendix. And we describe how the margins are presented. In this case, the margins are free, and the clinicians or the surgeons know, okay, now we're dealing with a tumor. It's not just a appendicitis anymore, right? Again, that decision tree, we turned this into a reactive or infectious process to a tumor, incidental finding of a tumor. And we do have in our pathology report some additional comments. In this case, additional comments, I described the finding from the immunohistochemical stains. And we have a section to describe, we notified the surgeon, because this is a incidental finding of a tumor, and it changes the patient's management, right? And because they need to follow up the patient to see if there's any tumor elsewhere, things like that. So why do we give all this microscopic descriptions? Because the clinician may not even know what we're talking about with all these jargons, right? So for a few purposes, first of all, this is documentation. We need to document what we see. And this is like our thinking process, our rational thinking, like how I derive to this diagnosis based on what we see. And this serves as a purpose. If the case goes to another hospital, the patient may want another pathologist elsewhere to review the slides. And this is the communication with our peers. And another factor is if somehow a lawsuit happened to this, then we are, we're showing our thinking process is very protective to pathologists, right? So the structures of a pathology report. Another big part for tumor is synaptic report or staging report, right? You may still somehow recall this picture we have from CAP, cancer protocols, and we need to do grading and staging of the tumor. And this is an example. This is the staging summary for this particular 15-year-old incidental finding in the appendix. And in this synaptic checklist or reports, what we describe is like the tumor site, the grade, in this case is well differentiated or grade 1. We have other parameters, including tumor size, extent, how far or how invasive it is toward, what level of the wall of the appendix, and margin status, lymph node, and staging. Staging is to tell the clinicians how aggressive it is. And in this case, since the tumor is on the outermost in the serosal surface already, it's not that low grade anymore, right? The incidental finding, we gave them a PT3, pathology grade 3 tumor. And a lymph node and other metastasis is not assigned because they have no idea it was a tumor. They did not do any lymph node sampling or check any other organs. So that kind of wraps up the structure of a pathology reports. Okay, I will just give you how we're doing on time. All right, I'm gonna give you a few kind of interesting stories. Okay, yeah, I'm gonna hurry up a little bit. Pathologist challenge. Pathology is rewarding and challenging, right? I'm gonna give you, I say, the fear and nightmare in our, collections. I'm gonna skip this. Okay. Pathologist's worst nightmare. And this story is good to tell to our other pathologists and other audience. Okay, this is a lymph node fine needle biopsy. It's a core of lymph node from a axilla of a patient. This core of the lymph node is okay. So pathology reading, this core is actually benign. It's a benign lymph node. I did some immunohistochemical stains to show CD20 positive B cells, all these brown colored cells, and CD3 positive T cells, right? And what I noticed, there are a couple of pieces here. These two pieces, they, okay, they are stained for CD3, so they're T cells. But however, in the Ki67, which to show the proliferation index, they are so proliferative. That makes me really, really worried because benign tumor or benign T cells don't do this. And now we are having a benign core lymph node with these two tiny pieces of tissue. I have no idea where they're from or where they belong to. And I put a lot of thinking and investigation to it. Unfortunately, I remembered at the same time of, when we get this lymph node, there was another specimen growth in by the same PA, pathologist assistant. And the other case was a pediatric case of acute T lymphoblastic leukemia, which is a leukemia case, a T cell, a highly malignant leukemia, right? That's how I would put it for now. And then that's the staining pattern is just perfect for that case. And the our EPIC can track the growth time for cases. And under these two cases, this is a bone marrow with that T lymphoblastic leukemia. The growth time is 10:20. And the other case, which is the lymph node, the growth time is 10:23, 3 minutes apart. Now we got an answer. This is a tissue mix-up. I mean, that's the worst nightmare that we would encounter. But we are not so lucky all the time. For this case, we found the answer, but there are cases we just have no clue. We could not find the answer. Okay. We're thinking about lawsuits. We're thinking about what are we going to do. We have to write up reports and then get the patient back. And sometimes we have to do molecular analysis to see if those two pieces are from the same patient. It's just, hard to imagine. So, okay. this is the last case of the day. And I know we have some pathologists listening to today's talk. They probably won't be satisfied if I don't mention this, because this is so famous and well known in pathology world. So this case is an elderly female with some abdominal pain, anemia. A endoscopy is done to the stomach. All right, they found a 2-centimeter enteral ulcer. And some biopsies are taken. We have some benign looking glands, right? The glands are round, they're nice looking. And there are some background cells. For an elderly female to have some chronic gastritis is just not abnormal. Thus, we see that frequently. However, all right, yeah, we see this. This is a ring, right? And higher power view on those infiltrating on those areas with a lot of the single cells. Actually, those cells have some atypia, even though they're small. They're really bland looking. Our powerful immunohistochemical stain, in this case, cytokeratin A1, A3, highlights those cells. This is the biggest fear of pathologists, missing Linitis plastica, which is an infiltrating, poorly differentiated carcinoma of the stomach. The architecture won't help because, the architecture is not really too distorted. It's just have some areas without glands and inflammatory looking cells, but there are cells hiding in there. This is a good way to describe this entity. And signet ring is usually a word we use to describe the morphology of this type of poorly differentiated carcinoma. Okay, and so there are two types of pathologists: those who have missed signet ring cell carcinoma and those who will someday miss signet ring cell carcinoma. It's just, past this words, passed generation to generation in pathology training. It's like so well described for how tricky those cells could be. And so every time when I saw gastric biopsies, this would come across my mind. I showed this case to our GI pathologist, or gastrointestinal pathologist in the department, and she just had a 3 months maternal leave and just came back to work. And she saw this case, just said, wow, this case woke me up. So, all right. Okay, just to touch a little bit on the malpractice for pathologists. These are some data slides provided by our, Dr. Feng Li, who is we call it 3D pathologist. He has an MD, a Juris degree, and a PhD degree. And so from his provided slides, there are top 10 specialties that are most likely to be sued. Good news for pathologists is we're not in the top 10. All right, pathologist is not within this list. And in general, like when the physician reaching retirement age, there's 50% chance that he or she will be sued at least once. Male doctors are more likely to be sued than female doctors. Okay, for pathology, this is like with malpractice claim annually, and pathologists is not very high comparing to like the malpractice claims annually. And the amount they have to pay is actually fairly high. All right, it may not be a good news for pathologists if they got sued. For pathologists, they're less likely to be sued, but once they're sued, is less likely they're being dismissed. So they're more likely to get sued successfully, put it that way, or comparing to the numbers of dismissed pathologists, the lowest. And also comparing to other specialties, pathologists more frequently to get a trial verdict. Okay, so this number is higher, and the trial verdict reached for pathologists, right? Okay, the last but not the least is for digital pathology and anatomical pathology, AI in pathology. So this information is kindly provided by Dr. Limin Yu, who is the director of pathology at Path AI. And so for traditional pathology, we have the workflow from slides to microscope. After we view the slides in microscope, we render diagnosis. And then if we want to share this case, we send the actual slides. We mail them to another pathologist, like through mail. Right? In a digital pathology, replacing the microscope is a scanner and a computer. Right? So instead of looking at under the microscope, the slides got scanned into images, and pathology look at the images on a computer screen and to share that to other pathologists through the internet. And many pathologists can be involved. They can render their consultation simultaneously to have different opinions, right? So this is the power of digital pathology. And okay, just to mention this briefly, because this is FDA approved. On top of digital pathology, we are able to develop artificial intelligence, AI, to process pathology images. And in this case, is the page pathology, a page prostate has been approved by FDA, and this page group has developed this algorithm from this after the deep learning of this pathology slides on prostate biopsy. They're able to render diagnosis to help pathologists in diagnosing prostate cancers, which is a very important cancer, for elderly male. And now this is like in use. Probably not a lot of institutions are using it, but this is FDA approved, and to show the AI's role in pathology. The last case, or say example, we are, I'm introducing is like, since our human eyes looking at microscopic slides, there's a lot of variations, right? For example, these are some liver biopsies for evaluating non-alcoholic steatohepatitis, NASH. And all these big bubbles here, you see are adipose, are fat, right? Are fat for fatty liver. And what we need to do when we evaluate this, we need to give a percentage. We'll say how many hepatocytes are involved by fatty changes, and are humanized between the pathologists. There's a big variation. The inter-observership reliability is very inconsistent, right? And now they're developing some treatment, some trials to evaluate patient. When for patient to enter the trial, if like we use our interpersonal just like our human eyes to evaluate, because of the inconsistency, it's hard, right, to select a patient entering the trial. And also for treatment evaluation, afterwards was the reduction of the adipose tissue or the fat in the liver. This is all a very realistic, practical issues that we have to address. Now this is where Path AI comes up, So the workflow, Path AI and Dr. Limin Yu's group has developed is they scan, right? So this part is the digital pathology. They created these images. Now those computer programs, after deep learning, they are able to identify all these adipocytes, or say fat in the liver cells, and this is like the inflammatory cells in the portal tract, or to see the hepatitis, and also they're able to identify the fibrosis through this AI program. Okay, so that really gives a consistent, more or less a objective evaluation for liver biopsies prior and after the treatment or entering the trial. I think this is highly valuable from a Path AI. Okay, wow. So this is the end. Thank you so much for your time. I know this went a little longer than expected. Having said all these fun factors about pathology, I want to, I'll let you know that pathology is like a cup of tea with all these spices added, and you have to learn to enjoy. Thank you.
Thank you, Yanxia, for such a comprehensive and a contemporary lecture about pathology. I hope you all feel pathology has been demystified with Yanxia's lecture. So before starting Q&A, in addition to the acknowledgement to Yanxia, I would also like to thank the people behind the scene, particularly our ANACP Education/CME Committee, our student volunteers and others for their effort and also contribution for this presentation. So now we can open our Q&A. Yanxia, can you see?
Yes, I can see them.
Okay.
And I think I'll start addressing them by reading what all right, 1 second. Now we have, okay, I'm looking for looking for pathology observership now. Okay, now, yeah, this is from Xiaodun. Do you have any suggestions how to make full use of observership and how to interact with and learn from residents attending during observership? Sure. I guess that's a good question. We have a lot of foreign graduates, especially Chinese medical graduates, going into our practice. And for now, ANACP and Kappa has this, joint effort to help applicants especially from this Chinese medical school background. And we do have mentorship programs, and we have people responsible for those and then in charge of those. And observerships are absolutely necessary to get more clinical exposure for pathology, since this is the part that we're missing from China, right? How to interact with and learn from residents and observership. Well, at this point, since you're applying, right, to use, I think, the best common sense, and then, how you interact to show your interest, and how, you're willing to learn. I'd say maybe we can have more, we can talk more about it offline, how you're able to do this. I know there are programs offering observership, and then in the US for us, right? So I'm gonna read more questions, and then
Yanxia, I think Dr. Wang Tao would also like to give comment or answer the first question, right?
Okay, yes.
Sorry, yeah, this is Tao, and I'm thinking, today mostly it's a CME lecture, and we will probably conserve the time for the education part. Actually, I have quite a bit questions I want to ask, but let Yanxia finish the rest.
Yeah. Okay, so I'm just looking at the Q&A. May I ask if there's any advantage of pursuing AP or CP only programs compared to AP SC combined programs? I'd say 95% of residents pursue the combined programs, and AP only. I know if people who wants to do forensic only would just go to AP only, and CP if they know their goal, they want to do only laboratory, a certain type of laboratory work, they would do CP only, but 95% would do AP and CP combined program, right? And I'm reading this, how to avoid misdiagnosis if a lesion is not in the certain section being examined. And this is necessary to examine all the sections of a tissue. We don't examine all the sections of tissue or an organ. You would imagine the organ can be big, right? If you have a certain organ like a breast carcinoma, or if you have entire Whipple specimen, which has a portion of a appendix, a pancreas, colon cancer. Sometimes if the lesion or the tumor is small, we do examine everything in that focal area. But I'd have to say, pathology, we play odds. And we have protocols. How to gross in specimen, how you examine, how you do your grossing following some guidelines, and to assure you not to miss in most of the time. But there are many times that we would ask to say, hey, go back and submit more specimen, submit entire specimen. That indeed happens. But we cannot really afford to examine all the tissue under the microscope. Okay. I think, have you ever been sued for malpractice? Yes, I have. I'd say many of us got involved by some lawsuits, and most of the time we got locked out. I mean, this is not pathology as part of the lawsuit of an entire medical team, right? Including they will sue people, all the doctors involved in this case, including surgeons, including hematologists, oncologists, including, and we are part of it. And a lot of times we're not responsible for that, but there are times we're not that lucky. But that's like pretty much true for all the medical specialties. I mean, we face that. That's part of the game. Can a pathologist do work multiple sites to earn more money? Yes and no. Mostly no. Right? Okay. So I think Wang Tao ask her question.
Because internal medicine doctor, we send in for pathology request for a lot of things, and actually your lecture really kind of like open a different angle for me to see pathology, especially when you say the nightmare and the mixed tissue, that part. It's so you were able to identify the grossing time of the two different specimens, and then it sounds really the importance of grossing make a difference to your diagnosis, right? And also for the appendix pathology exam, the few examples you gave to us, and I really see grossing is important, right? You have to pick the exact place in order to see the right picture. So is that true? You have to really look into your assistant, make sure they do the right thing.
Exactly. So through our training, we learn how to gross specimen. That's absolutely critical. You can either make your life a lot easier, or you can make your life a nightmare. And during this process, we do make mistakes, right? And our attendings would tell you, how things should be done, and it's not done in the right way. And in our practice, we have a PA, pathologist assistant, to gross in the specimen, and they are very experienced. And by examining specimen grossly, like to see how things are going and then how things look and what sections, what areas to submit. We follow protocols and we have solid trainings to help us identify that. But indeed, this is sometimes it's art. It's, we have really a lot of times I pray for my job, my daily practice, not to make mistakes and then catch things like in the lollipop type of pictures. But you're right, solid training, a very good sense. But these are all trained, acquired skills, and we're able to get after all these years of training.
Thank you. That's a very good point. The other question I have is, especially when you describe the case with the fish tank with the wound, clinically you have to know a lot of details. So what do you expect the clinician put in the test request? How much history? You have to dig a lot in order to get all the informations, right? But what do you think we can do better? Something. So anyway, that's one thought I have been
indeed
having.
That is a very, very interesting case, and I shared with a lot of people, including in our WeChat group in Kappa. And then by the time we got the specimen, I did not really have all the details in the history, and those notes actually appeared a few days after my diagnosis was made. I did not really have those notes. And that's like, part of we don't have those knowledge. I did not know the patient started first symptom really 5 months ahead of, like, before all this, the specimen was submitted. But luckily, I ran into this infectious disease doctor. He was really puzzled. This patient is a physician in our hospital. He's a gynae doctor in our hospital. And he knows her personally. And he's really puzzled about this case. And then he thinks, what about why is it such a long-lasting wound? It wouldn't heal. And we started talking more and then digging out more in her history. I saw those notes and started this AFB stain. This case is absolutely, it's very, very tricky. So that's what I emphasize, the clinical pathological correlation, communication. If there's something does not make sense, the whole picture does not make sense, either talk to your clinician or you as a clinician, you call pathologists. You call them. And I like to talk to them, even though sometimes we would think there's something wrong with my diagnosis when they call. But we love to talk to them to get more communication. So talk to the pathologist, pick up the phone and call pathology office and then talk to, why do you think of this? Would you mind to relook at this or that? That's all legit request.
Okay. Actually, follow that line. When you decide what the IHC stain you want to do for certain things, how do you choose that? That
is training. So what we choose that, we have hundreds of immunohistochemical stains, IHC stains, as you said. And we start from the morphology, right? What we suspect to start with. The big categories of a tumor, if it's malignancy, what type of, carcinoma, sarcoma, melanoma, lymphoma, leukemia in our decision-making tree as a very top layer. Most of the time I'd say 90% of the time, when we see the morphology under the microscope, we have an idea what category it belongs to, but there are some tumors which are very poorly differentiated. We are not able to point to a direction at the first glance. And we have to kind of do broad spectrum of immunostains to narrow down what it is. So we decide on what I see based on morphology, based on what tissue organ, and there's also a lot of clinical correlation as well to select what panels of immunostains we want to use. That's what all this 6 years of training would do to you.
Okay, it's similar like internal medicine. We do differential diagnosis, right? Go to different paths. And let me ask you the last question. I will give the time for other people to ask. I order a peripheral blood smear, not fairly often, but when there is a suspicion. And oftentimes I got the report says, okay, it's similar to the autonomic differentials. Okay, all the cells looks fine. I was thinking, okay, have you seen anything that's weird on the peripheral smears?
I do daily peripheral blood smear review because I'm hematopathology and I'm trained to look at peripheral blood smears, bone marrows, so blood cells. And for our review, every case I look up the pathology or the clinical picture to see why they send for a smear review. If there's anything they suspect in their mind, I try to see what you are thinking, right? When you order a peripheral blood smear review. For our diagnosis, we look at the CBC, right? The numbers. We look at the morphology, and including all the different cell types, white blood cells, red blood cells, platelets, and we render a diagnosis. The problem is, I have to say, a lot of times, peripheral blood smear review is how much it may give you a sense what's going on. A lot of times, it may not be able to explain your clinical finding. If the patient has anemia, all right, and then the things that we are able to identify, something very definitive, very solid from peripheral blood smear review, if the patient is having chronic leukemia, like chronic lymphocytic leukemia, CLL, or the patient has acute leukemia, or the patient has some abnormal cells can point to an iron deficiency. In those cases, you may have a good, solid answer from peripheral blood review. Because a lot of times I sign out my case as like reactive lymphocytes. Reactive doesn't tell you anything. I mean, or reactive lymphocytosis favor reactive. And if lymphocytosis persists, you can run flow cytometry to see if those are neoplastic lymphocytes, right? It's fairly limited, unless there's like an obvious morphology evidence of malignancy or neoplastic process. Yeah. You can call the pathologist and then call and say, what do you mean by this? Do you think of the lymphocytes are abnormal? Those are all fine. I would encourage you clinicians call our pathologists to chat. Shunghua, yeah?
Yeah, yes, there is another question show up.
Okay.
Can you see
it? Given the development of AI, right? Is that the one we're talking about?
Yeah.
Okay, so I'm going to read the question. Given the development of AI to assist with pattern recognition and diagnostic process, where do we see the role of pathologists in a few years? Very good question. It's $1 million question, right? The short answer is in a few years, nothing's going to change, not too much. Probably not in 5 to 10 years. We pathologists will still sit in our office, do a lot of things. Maybe digital pathology would be more and more prevalent or popular. microscope might be less and less useful. But AI without pathologists is, I don't know, it's gonna be really far away. Pathologist job market will not be hurt that bad recently or in a few years. I don't think so. And a lot of institutions may not have the incentive to do AI yet because there's a cost and a benefit balance. At this point, nothing is too dramatic to say we don't hire pathologists and we do AI, as we're just not there yet at all, right? Let's just say another question is how trustworthy of a pathology report from China that we commonly encounter for a second opinion consultation. So it sounds like this is from a clinician. You receive a surgical pathology report from China on this patient. The pathology training and pathology workup in China is the training is probably getting more structured nowadays, or say it's recent years. But in the past, the pathology training in China was not very structured. That's what I heard. And the pathology report, I would say most of the time, they are more or less on the target. It depends on what type of diagnosis you encounter. That, of course, you want to have if it's possible, but a lot of times it may not be possible for them to get a second opinion here at US if you're treating the patient in US. I'm not really sure to give you a yes or no answer. And this is like, you have to decide on your own whether you want to repeat the biopsy, which is not a bad idea if you have the patients, right? But just by looking at a pathology report from China, sometimes we get to do that as well. We can add some opinions, say maybe you can run this and that, but their diagnostic skills in general is pretty good. I would say it's still very good. Is that pretty much all the questions? If anybody wants to raise their hands, they can, they'll be able to raise their hands and talk. Do you guys see more questions, or that's pretty much it?
No, I don't see any more questions from my side. Yeah.
Oh, okay. Yeah.
I think, yeah.
That's good. That'll conclude tonight's talk then.
Thank you again, Yanxia, for such a wonderful talk about pathology.
Thank you.
It's very helpful.
Thank you, guys.
Yeah, I think we can conclude our presentation today. And thank you, everyone, and enjoy the rest of the weekend. Okay, bye.
Recording stopped.